So the encephalopathy that we see in Ebola is not too dissimilar to the encephalopathy that we see in a variety of infections. A lot of times we chalk it up to what's called toxic encephalopathy. Whether or not Ebola actually targets the CNS and infects the immune cells in the CNS, it may, because Marburg has been suggested to do so. But either way, whatever the cause, the encephalopathy likely will get in the way of your care unless you have a strategy to manage it. In the U.S., we have a lot more ways to manage that because if you need to sedate someone to the point of respiratory depression, then you can just control their airway and be able to ventilate. In West Africa, we had to walk a much more narrow tightrope because the therapies for their agitation and their encephalopathy actually could get you into more trouble in terms of management. It was actually one of the biggest things that limited the care we were able to provide in West Africa because for a number of the patients, we couldn't get them safe to the point where we could actually do any interventions. So it hadn't been well described in previous outbreaks, but it's clearly a predominant feature, especially as they get sicker, and it becomes a bigger struggle in the premorbid state.
And at least in the experiences that I know about globally on patients who have required intubation and mechanical ventilation, the other thing that certainly the encephalopathy has been very common in those patients, but it's also been somewhat challenging to sedate some of these patients. They've required not insignificant amounts of sedatives and analgesia to keep them calm on the ventilator. Which is, I think, a little bit more severe than we would typically see in critically ill. We don't generally need this much support in that setting.
And just one follow-on point to that, some of the people who we saw out there had almost meningismus-like findings. They had hypertonicity, and in talking with my critical care colleagues, some of them thought the patients actually could be storming. So one of the strategies in terms of being able to sedate these folks may be to consider ketamine sooner than later. Again, it obviously depends on the clinical situation, whether or not you think the patient is safe to receive ketamine. But I think the problem is we're still in the early learning phases of this disease and still trying to figure out, because again, most of our stuff is translated from West Africa to the U.S., and we don't have sufficient patients in the U.S. where the resources are there to try and figure out are some of our theories actually going to be useful, or were they just a good idea that actually didn't pan out in the patients.